This module covers a general review of cardiac arrest, including how to recognize cardiac arrest, routes of drug administration that we may see used, and some specific medications that we may see given during cardiac arrest. Cardiac arrest is defined as the cessation of blood flow due to the absence of or inefficient cardiac activity. The usual cause of cardiac arrest is some sort of cardiac arrhythmia. However, in children, the most common cause of cardiac arrest is the progression of respiratory depression. The signs of cardiac arrest include no palpable pulses, apnea, or agonal gasps, unresponsiveness, the absence of adequate breathing or coughing, and no movement upon stimulation. The most common cardiac rhythms associated with cardiac arrest include ventricular fibrillation, pulseless ventricular tachycardia, and asystole. Let's talk about some of these specific medications that we may see used for cardiac arrest in various other emergency situations. The vasopressors commonly used in cardiac arrest are epinephrine and vasopressin. Epinephrine may be given IV, IO, IM, or ET. The dose may be repeated every 3 to 5 minutes in cardiac arrest. If giving epinephrine IV, use the 1 to 10,000 or 0.1 milligram per mil concentration. The dose is 0.01 milligrams per kilogram or 0.1 mils per kilogram up to a maximum dose of 1 milligram. If giving epinephrine ET, the 1 to 1,000 or 1 milligram per mil concentration should be used. Each dose is diluted with an equal volume of normal saline up to a total volume of 10 mils and followed with a flush and 5 positive pressure ventilations if CPR is in progress. When making an epinephrine infusion at the bedside, add 11 mils or 11 milligrams of the epinephrine 1 to 1,000 solution to a 100 ml bag of D5W or normal saline. This will provide an epinephrine drip that is 0.1 milligram per mil or 100 micrograms per mil. If a physician asks for an epi spritzer in a code, then he or she wants you to add the code dose of 0.01 milligram per kilogram of epinephrine 1 to 10,000 in a 10 ml flush. Then draw up doses of this solution in 1 ml increments. They will dose 1 ml at a time until the desired effect is accomplished. Epi spritzers are most commonly used for bradycardia and hypotension. Vasopressin is not one of the PALS recommended agents to treat cardiac arrest. However, vasopressin is sometimes used with a patient who is not responding to epinephrine for pulseless arrest, ventricular fibrillation, or ventricular tachycardia and septic shock. Another class of drugs we commonly see used in cardiac arrest are the antiarrhythmics amiodarone, lidocaine, and magnesium sulfate. Amiodarone may be used for ventricular tachycardia with pulses by using a loading dose of 5 milligrams per kilogram. Lidocaine vials are available in the crash carts and in the code bag in a 2% solution that is 20 milligrams per mil. In patients who have decreased hepatic function or renal function, only half of the loading dose should be administered. When being used during rapid sequence intubation, the lidocaine dose is 1 to 2 milligrams per kilogram. The bolus dose is sometimes followed with a continuous infusion at a concentration of 8 milligrams per mil. Magnesium sulfate is indicated for the treatment of torsades de pois, refractory status asthmaticus, and hypomagnesemia. Magnesium sulfate can act as a smooth muscle relaxant and an antiarrhythmic by acting as a calcium channel blocker on the heart. The dose of magnesium sulfate varies depending on indication. If administered too quickly, magnesium sulfate can cause hypotension or bradycardia. Another medication commonly used in cardiac arrest is atropine and is indicated for bradyarrhythmias and symptomatic bradycardia. Atropine also has a role in rapid sequence intubation when succinylcholine is being given. It works by blocking acetylcholine and muscarinic agonists at the parasympathetic neuroeffector site. Atropine doses should be administered rapidly to prevent paradoxical bradycardia. Calcium can also play a role in the treatment of cardiac arrest. It's used for the treatment of hypocalcemia, hyperkalemia, or for calcium channel blocker overdose. Calcium is utilized in most cases to help provide cardiac stabilization or to calm the heart. The dose of calcium chloride is 20 milligrams per kilogram and can be given over 10 to 20 seconds in cardiac arrest. No dilution is required in code situations. If 2 boluses are successful and more calcium is required, then a solution should be prepared at a concentration of 20 milligrams per ml and infused over 1 hour. Calcium gluconate is the formulation of calcium that is preferred in neonates and infants. The dose for calcium gluconate is 100 to 200 milligrams per kilogram, up to a maximum dose of 2 grams. Calcium gluconate must be diluted prior to administration to infants. Sodium bicarbonate is indicated for the management of severe metabolic acidosis, symptomatic hyperkalemia, tricyclic antidepressant overdoses, stabilization of acid-base balance, or prolonged cardiac arrest after epinephrine has been administered with little success. Boluses should be repeated every 10 minutes until serum pH is greater than 7.45. In neonates and infants, sodium bicarbonate should be diluted 1:1 with sterile water to provide a solution that is 0.5 milliequivalents per ml, and the rate should not exceed 10 milliequivalents per minute. This concludes the cardiac arrest module. You may review this again at any time.